This is ABSITE and oral board review for esophagus. Let's start with anatomy. You should divide the esophagus into 4 sections: cervical from the mouth to the thoracic inlet, upper thoracic from the thoracic inlet to the tracheal bifurcation, lower thoracic from the tracheal bifurcation to the esophageal diaphragm hiatus, and intra-abdominal, which is 3 to 4 centimeters from the esophageal hiatus to the angle of His at the GE junction. For the blood supply, the cervical esophagus is from the inferior thyroid artery via the thyrocervical trunk, upper thoracic from bronchial arteries, lower thoracic directly from the aorta, and intra-abdominal from the left gastric artery and the phrenic artery, which are connected via Bell's artery. 3 narrow areas of the esophagus are the cricopharyngeus muscle, also known as the upper esophageal sphincter, the aortic arch, and the diaphragmatic hiatus. Think of coins stuck here in kids and rigid esophagoscopy to remove them. The layers of the esophageal wall are mucosa, submucosa, muscularis propria, and adventitia. There is no serosa. The muscularis propria is really 2 layers though, the inner circular and the outer longitudinal. Between these muscle layers is the Auerbach's plexus. This is important when we talk about achalasia. The esophagus is lined by squamous epithelium, and this transitions at the Z-line to columnar epithelium of the stomach. The esophagus snakes a little bit, so for surgical access, the cervical esophagus is approached from the left neck, the upper thoracic esophagus from the right chest, the lower thoracic from the left chest, and the intra-abdominal from the abdomen. Generally, the esophagus peristalses in a coordinated manner with a low percentage of synchronous contractions. As a food bolus nears the GE junction, the lower esophageal sphincter relaxes. In older units of measurement, there are 10% or less simultaneous contractions in the esophagus. The mean amplitude of esophageal contractions is less than 100 millimeters mercury, and the lower esophageal sphincter resting pressure is 15 to 25 millimeters mercury and relaxes to 0 with a swallow. Well, they had to go and make this even more complicated with something called the Chicago classification, which changes these numbers and terms. The measure for contraction strength is called the distal contractile integral, or DCI, and a number of less than 5,000 is normal. And the measurement for how the lower esophageal sphincter relaxes is called the integrated relaxation pressure, or IRP, with less than 15 being normal. The most common dysmotility disorder on tests is achalasia. The classic findings are aperistalsis, meaning there is no contractions at all, of the distal esophagus, and failure of the lower esophageal sphincter to relax. So likely the IRP will be greater than 25 without relaxation. The classic barium esophagram for achalasia is a bird's beak, or if it's really advanced, an esophagus that looks almost like a sigmoid colon. Achalasia histology, pathognomonic finding, is a loss of the Auerbach plexus between the inner circular and outer longitudinal muscles in the esophageal wall. EGD should be done in all achalasia to rule out malignant strictures, or so-called pseudoachalasia. EGD biopsy will not show the loss of Auerbach's plexus, since it would have to be a full-thickness biopsy to get the plexus between the muscles. We are not sure why the plexus has gone in some people. In Central and South America, Chagas disease from the Reduvier bug, or the kissing bug, gives you the parasite T. cruzi, which can attack the Auerbach's plexus, causing achalasia. The treatment for achalasia is sometimes endoscopic. Sometimes they inject botulism of the GE junction, or they can do a balloon dilation of the GE junction. These tend not to last very long, so the more definitive fix is a Heller myotomy. A Heller myotomy is almost always a laparoscopic surgery, and you should know that the myotomy is through the entire muscle layer until the mucosa pooches out, and this runs from 4 centimeters up the esophagus and down 2 centimeters onto the stomach. EGD is typically done at the end of the case to ensure the GE junction is wide open and to look for perforation. If a perforation of the mucosa is found, repair it with Forovicryl and leave a drain. I would always answer that after a Heller myotomy that reflux will be bad, so a partial wrap with either an anterior door or a posterior toupee will mitigate this. it is common to see the posterior toupee actually affixed to the edges of the myotomy to hold it open. The next common dysmotility disorder on tests is diffuse, which is the old nomenclature, or distal esophageal spasm, which is the newer nomenclature. This is DES. This is marked by a greater than 20% premature contractions in the esophagus, but otherwise relatively normal amplitude of contractions, with the IRP being normal. The classic barium swallow finding is a corkscrew esophagus, although this is really not very sensitive or specific to this disorder, but it is the one usually assigned to it on tests. The important thing to know about diffuse esophageal spasm, or DES, is that medical treatment is first line, which includes psychiatric treatment, as it is commonly related to stress, and medications such as nitrates, calcium channel blockers, and sildenafil, or Viagra. Another set of motility disorders to know about is nutcracker and jackhammer esophagus. These are both marked by high amplitude contractions, thus very high DCI numbers. The DCI for nutcracker esophagus is over 5,000, but if it is over 8,000, then it is called jackhammer esophagus, with another official term of hypercontractile esophagus. The IRP of the lower esophageal sphincter is normal, and the esophagram probably will be normal, but it could show a corkscrew pattern also. First-line treatment for nutcracker and jackhammer esophagus is also medical, with medications such as nitrates, calcium channel blockers, sildenafil. For distal esophageal spasm or nutcracker jackhammer, only answer that a long segment myotomy surgery could be considered only if a failure of medical management. Lastly, it's probably good to know that there is a procedure called POEM, which stands for peroral endoscopic myotomy. I would not use this answer on an ABSITE or oral board test at this point though, since it is relatively new. Esophageal diverticulums. A Zenker's diverticulum is a pulsion diverticulum that occurs at Killian's triangle, which is located just above the cricopharyngeus muscle, which is also the upper esophageal sphincter. The Zenker's is an outpouching of mucosa over the cricopharyngeus, and food tends to get stuck in the pouch that causes bad breath, dysphagia, and regurgitation of undigested food. The treatment is surgical with either a left neck incision through which the diverticulum is removed and the cricopharyngeus is divided. There is another technique by which a stapler is placed through the mouth and into the lumen of the esophagus and the diverticulum, and the stapler is fired to connect the lumens and simultaneously divide the cricopharyngeus muscle. A traction diverticulum is typically found in the mid-esophagus and is associated with an inflammatory problem in the mediastinum, such as tuberculosis. An epiphrenic diverticulum is usually in the distal esophagus and most commonly on the right. It is seen on esophagram best. If you find an epiphrenic diverticulum, always check manometry. If you have an epiphrenic diverticulum associated with achalasia, then staple off the diverticulum and also do the Heller myotomy. All right, let's talk about hiatal hernias. You should basically know the 4 types. Type 1 is the most common hiatal hernia, and this is where the GE junction slides into the chest, so it is known as a sliding hiatal hernia. You should fix a type 1 sliding hiatal hernia if it is large or associated with bad gastroesophageal reflux, since the negative intrathoracic pressure during breathing actually pulls acid from the stomach up into the chest and into the esophagus, giving you the reflux. Type 2 hiatal hernias, are also known as paraesophageal hiatal hernia, is the most dangerous type. This type is rare, luckily. The GE junction is still in the abdomen, but part of the stomach, usually the fundus, is herniated into the chest. This is at high risk for gastric ischemia. They also tend to bleed from ischemic ulcers called Cameron's ulcers and can present with anemia. Torsion of the stomach causes a classic Borchards triad, which is comprised of severe epigastric pain, unproductive retching, and an inability to pass an NG tube. This is a sign of a torsed paraesophageal hernia with the stomach torsed around itself. Fix paraesophageal type hiatal hernias if they're good operative candidates because of this risk of gastric volvulus. Type 3 is when both the GE junction part of the stomach herniate into the chest. Type 4 is the GE junction, portion of stomach, and some other organs such as spleen or colon or small intestine are all herniated into the chest. Any symptomatic type 3 or type 4 should have surgery if the patient is a surgical candidate. Although frequently you will find these in very elderly, frail patients, so if asymptomatic, you may be better just to leave them alone. Let's talk about Barrett's esophagitis. Barrett's esophagitis is from long-standing GERD, but only about 10% of GERD patients actually get Barrett's. Barrett's is squamocolumnar metaplasia, meaning that the squamous lining of the esophagus changes to columnar cells. And this is also marked by specialized goblet cells that are normally only seen in the stomach and small intestine. Surgical anti-reflux surgery does not cause regression of Barrett's, but it does prevent progression. Long segment Barrett's is defined as being longer than 3 centimeters and has a higher risk of cancer. Patients with long segment Barrett's should undergo screening EGD with random 4-quadrant biopsies of the involved esophagus every 1 to 2 centimeters, every 1 to 2 years. However, if you find low or intermediate grade dysplasia, you should have EGD with random biopsies more frequently, say every 6 months or so. High-grade dysplasia in Barrett's used to be treated with esophagectomy surgery, but now there is a procedure called endoscopic mucosal resection, or EMR, and that's an option that's probably a better initial step. I'm going to talk a little bit about gastroesophageal reflux GERD surgery. Briefly, you should know that anti-reflux surgery has a lot of opinions and gray areas, but here's a few safe answers. Before performing anti-reflux surgery, know if a patient has failed medical therapy or if there is a clear lifestyle limiting factor to medical therapy, such as patients just don't want lifelong medication. Clear surgical indications are Barrett's esophagus, peptic strictures, extraesophageal problems such as reactive airway disease from the reflux. Always check an EGD before surgery. Probably a good idea to do the 24-hour pH probe, especially if the EGD is relatively unremarkable. If those studies are pointing you towards surgery, I would also mention a manometry study prior to surgery, largely to rule out achalasia or other dysmotility that would be a contraindication to a full Nissen fundoplication. Barium esophagram can be a last confirmatory test for anatomy. For testing purposes, you should be very thorough in preoperative testing. Be sure to know the basics of Nissen fundoplication surgery. Briefly, you should dissect the hiatus and the distal esophagus circumferentially, close the posterior hiatus if it's loose with primary stitches, take the short gastric vessels all the way up the greater curve of the stomach, and wrap the fundus and greater curve of the stomach 360 degrees around the GE junction using a 56 French bougie so you don't make it too tight. Grab the stomach with the lowest wrap stitch to prevent sliding of the wrap. The partial wraps, the anterior door or the posterior toupee, are used if abnormal peristalsis is found on manometry, but the patient needs a reflux surgery. Okay, let's move on to caustic ingestion. Caustic chemical ingestion comes in 2 types. Acids, which cause coagulative necrosis, and alkali or lye, which causes liquefactive necrosis. Liquefactive necrosis from lye is obviously worse. Usually you are asked what are the initial tests in ingestion. Starting with a CT scan or a gastrograph and swallow to rule out frank perforation makes sense. EGD should be done within 24 to 48 hours to evaluate the extent of injury if no obvious perforation on initial imaging. If no perforation and stable, the person needs admission with empiric broad-spectrum antibiotics, IV fluids, and keep them NPO, and a careful observation bed. Remember that empiric steroids do not help. If esophageal perforation is found, the safe answer is to resect the necrotic esophagus via a thoracotomy and give a spit fistula in the neck, place a feeding tube in either the stomach if it's not injured also, or maybe a J-tube. Boerhaave syndrome is perforation after forceful retching. Usually it's on the distal esophagus on the left side. Other causes of perforation will be iatrogenic during endoscopy. Air in the mediastinum can cause a crunching sound on auscultation called a Hammond's crunch. The first best test, if suspicion of perforation, is gastrograph and esophagram. If no perforation is seen on esophagram, an EGD is a reasonable next step to evaluate the injury. If either test shows free perforation, then the patient needs surgery. At this point, you should decide if this is an early perforation diagnosed within 48 hours of injury, or a late diagnosis diagnosed later than 48 hours. Late diagnosis with necrotic, inflamed esophageal tissue would be treated similarly to a caustic ingestion with resection of at least the damaged portion of the esophagus, or at least very aggressive drainage and a cervical esophagostomy or a spit fistula. Always approach the distal esophagus from a left posterior lateral thoracotomy. Early diagnosis has less sick patients with less tissue necrosis and inflammation, and these would be the ones amenable to repair. For those early perforations that can be repaired, the way to do it is to say that the extent of mucosal injury is usually longer, so open the muscle layer of the esophagus to determine the extent of the mucosal injury. Repair the mucosa as a separate layer, then close muscle as a second layer, then buttress the repair with a flap of diaphragm, intercostal muscle, or pleural flap. Then you should make sure to leave an NG tube and a chest tube. Using an esophageal stent to cover a perforation is probably not the safest answer, and I would discuss this only very carefully in a perforation with minimal soilage and a very stable patient. Another common subset of this question comes from a patient having endoscopic dilation of achalasia that causes a perforation of the distal esophagus that could present with either mediastinal leak, but probably with some sort of perforation into the abdomen with free air, free fluid in the abdomen. This is treated with a 2-layer repair of the esophagus from the abdomen or the left chest if needed. In this case, with achalasia and a perforation, a Heller myotomy on the opposite side of the esophagus and a partial wrap of gastric fundus with anterior door or posterior toupee is probably the best answer. Again, this scenario should only be done in a very early diagnosis at the time of endoscopic dilation with a stable patient, which is really the only scenario where doing primary repair and a concurrent opposite side myotomy makes any sense. Lastly, know that a Mallory-Weiss tear also comes after heavy retching. Mallory-Weiss tears do not cause perforation, but they cause bleeding, which typically can be controlled with EGD techniques, but frequently these stop on their own. Let's talk a little about esophageal varices. Esophageal varices are related to portal hypertension. The portal vein is made up of the superior mesenteric vein, or the SMV, the inferior mesenteric vein, or the IMV, and the splenic vein. The coronary vein, which is also the left gastric vein, drains into the distal esophagus and connects to the splenic vein. So portal hypertension leads to esophageal varices, which can bleed. Initial treatment of bleeding esophageal varices is octreotide or somatostatin, proton pump inhibitor, and if the patient is very unstable, you can try using a Seng-Staken-Blakemore tube, which is inflated in the distal esophagus, and EGD with banding if the patient is stable enough. A TIPS procedure, which stands for transjugular intrahepatic portosystemic shunt, which is done through the liver from the hepatic vein into the portal vein, will decrease the pressure in the portal vein if there is recurrent or refractory bleeding problems from esophageal varices. TIPS can lead to right heart failure and can worsen hepatic encephalopathy though, since it bypasses blood right through the liver. There are a few benign tumors in the esophagus. The most common is leiomyoma of the esophagus. This is seen as a smooth filling defect in the distal esophagus with normal mucosa on endoscopy. I recommend do not biopsy from EGD because it can cause a scar to the mucosa that makes surgery even harder to do without tearing the mucosa. If a leiomyoma is over 5 centimeters in size or symptomatic, Then you should resect it from the thorax side, leaving the mucosa of the esophagus intact. Another benign finding in the esophagus is foregut duplication cysts. Endoscopic ultrasound, or EUS, may help confirm the diagnosis of a foregut duplication cyst. Usually these also only need enucleation surgery from the thorax side. Plummer-Vinson syndrome is a syndrome marked by spoon-shaped nails, iron deficiency anemia, and esophageal webs. A Schatzki ring is a benign stricture of the distal esophagus that food can get stuck in, and sometimes an endoscopy is needed to push or pull the food out of it. Okay, let's tackle the big topic of malignant esophageal cancer. So adenocarcinoma of the distal esophagus is increasing, while squamous cell cancer of the esophagus, which is typically in the more proximal esophagus, is decreasing in incidence. Esophageal squamous cell carcinoma is increased in patients with scleroderma and achalasia, and also increased in patients that smoke and drink alcohol. Cervical esophageal squamous cell carcinoma is usually treated with definitive chemoradiation. However, most test questions focus on distal esophageal adenocarcinoma, so we will focus on that. So risk factors for distal esophageal adenocarcinoma are GERD, reflux, and obesity, which is related to GERD, Barrett's esophagitis, and achalasia. So remember that the layers of the esophagus are mucosa, muscularis mucosa, submucosa, muscularis propria, then adventitia. There is no serosa in the esophagus. For the T stages for esophageal cancer, know that if a cancer has not penetrated the muscularis propria, which is the two-layer intercircular outer longitudinal muscle layers, then it's considered T1. When it's actually into or through the muscularis propria, then it's a T2. If it's penetrated through the adventitia, it's a T3. And if the tumor is invading other organs, such as the aorta or the trachea, then it's a T4. Endoscopic ultrasound is good for T staging. Neoadjuvant, or treatment prior to surgery, is a cloudy subject, although I think safe assumptions are that T1 tumor can go straight to surgery. Invasion of the tumor through the muscle of the wall or clinically node positive, so T3 or N1 or more, you should probably think pretty hard about neoadjuvant therapy. Radiation alone is not a good option. It's usually a neoadjuvant chemoradiation is acceptable. Sometimes very distal tumors near the GE junction or the intra-abdominal esophagus are treated more like a gastric cancer, which is more commonly neoadjuvant chemotherapy. It may be good to know the Siewert classification. Siewert 1 is a tumor just above the GE junction and is more like a true esophageal cancer. A Siewert 2 tumor involves the GE junction and extends a little bit into the esophagus. A Siewert 3 tumor is a gastric cardia tumor that extends close to the GE junction but not much past it. You can remember this because it looks a bit like a pyramid going from 1 down to 3. The main reason to know this classification is because Ivor-Lewis esophagogastrectomy surgery is best for Siewert 1 and 2 cancers. A total gastrectomy with a Roux-Y esophagojejunostomy is the best choice for a Siewert 3 tumor, since it's really treated more like a gastric cancer. Let's focus a little bit more on esophageal resection surgery. For your purposes, there are two main ones: an Ivor-Lewis with an anastomosis in the chest, and a transhiatal esophagectomy with anastomosis in the neck. The stomach will almost always be the conduit. Know that the lesser curve and upper stomach are removed with the specimen, while the greater curve is tubularized to become the new esophagus. The blood supply to the new esophagus is the right gastroepiploic artery, which is a branch off the gastroduodenal artery, or the GDA, which is a branch from the hepatic artery. For an Ivor-Lewis surgery, once the stomach is tubularized, the right chest is opened and the distal esophagus and upper stomach are removed as the specimen, along with lymph nodes from the lesser curve, the left gastric artery nodes, and the periesophageal nodes. Then, since the esophagogastric anastomosis is made in the chest, we often consider pyloromyotomy since the vagus is gone, and often we place a jejunostomy feeding tube distal to this. Transhiatal esophagogastrectomy is similar, although the anastomosis to the esophagus is in the neck via a left cervical incision. Proponents of the transhiatal esophagogastrectomy argue that no thoracic surgery is needed, so there's less pulmonary problems, and that a leak in the neck makes a patient less sick than a leak in the chest. Another common scenario is when the gastric conduit dies or leaks. The answer to this is that a spit fistula is used to stabilize the patient, and the next esophageal conduit to use is a colonic interposition surgery. Well, that was a lot, so good job hanging in there. I hope this helped. Thanks.